though, as you know, and why you're here, the Sustainable Healthcare Coalition engagement meeting. So we're really pleased to be with you all. We've got a really great day today. Just to remind everybody that it's a pre-competitive meeting, and obviously we're here really to advance the cause of sustainability in healthcare. We're just going to preview our agenda for this morning. Keith, if you could pop that up, that would be great. This morning we've got a fantastic lineup. We've got Annie McGregor from ABHI, we've got Mike Crooks from the University of Hull, we've got Arup and John Craig from UCL Partners, and then later on after the coffee break we're looking at pharmaceuticals and the environment with Sharon Flager and Kelly Thorber, who've done a huge amount of work on this agenda, and then with Andy Clark from Bayer, and then Shaheen Ramford, we're looking at circularity. So really good morning coming up. So I think as we're all here and ready, we might as well start with Addy. Addy, as those of you who don't know might know, is actually a sustainability manager at the Association of British Health Technology Institute, ABHI, and we're really pleased to be partnering a lot with Addy and also Luella on a number of initiatives. And we asked Addy really to give us an overview of the work that she's been doing recently. So Addy, over to you.
Thank you. What a lovely introduction. As Fiona said, my name is Addy McGregor and I am the Sustainability Manager at ABHI. I'm going to be giving a bit of an industry overview today as to how things are going. So for those of you that haven't come across ABHI before, I thought I'd do a little bit of the preamble. So as Fiona said, it's the Association of British Health Tech Industries, and so we are the industry body for medical devices, diagnostics and digital health. So we've got about 400 members in our membership. Don't worry, I'm not going to go through the whole slide. But they very much range from SMEs to big, large multinationals, as well as a number of other organisations relevant in the space, such as regulatory consultants or law firms. What I think is important to note is that, as is reflective of our industry, our membership is about 90% SMEs. And so I think it's always important to remember that when we're considering anything in this space, really. So I just wanted to put this up. I'm hoping that the majority of people know this very well, or at least a bit. This is the NHS Net Zero Supplier Roadmap. And I'm not going to talk to it in great detail, but just to highlight that this is what all suppliers to the NHS are currently abiding by. And to highlight that we're now at the point of April 2024, where the carbon reduction plan requirement has expanded. So it's all new frameworks will require it, irrespective of the size of it. And that's for scope 1 and 2 and subset of scope 3 emissions. I'm happy to have a conversation with anyone about this afterwards, but just wanted to kind of very briefly say that this is where we're at in the process. So the main thing that I wanted to talk about today is that we recently published a paper, and that is Health Tech and Sustainability, the Opportunities and Challenges for the Sector. So this is following a number of roundtables with our membership last year, and they covered those 5 themes at the bottom. So that's regulatory barriers, NHS Net Zero Roadmap, adoptions of innovations into the NHS, funding and research pathways, and then government policies. And the aim of this paper is to highlight some of the things the industry is already doing and the areas that we can go, but predominantly it was to highlight the complexity of the sector and partly the reason why we're not doing some things yet, but we are working on them. So the paper makes a number of recommendations I'll go through briefly in a minute, but it's essentially split up into 3 sections. So it's partly towards the NHS, partly the regulator, so the MHRA here in the UK, and then recommendations for government as well, so the wider government department, so for organisations like Office for Life Sciences, Department of Health and Social Care, Cabinet Office, Treasury, any other department that is relevant for our sector and is part of it. Also, this is, anyone can read this, you don't need to be, excuse me, one sec. Excuse me. Anyone can read this, and I'll put a link in the chat as well afterwards, so that everyone can access it. So throughout the whole paper, there are a number of themes that I think need to be considered. Otherwise, in essence, I'd be repeating myself a lot. And some of the themes are, so international collaboration. We very much know that our sector does not work in isolation in the UK. It's quite hard to find manufacturers that only produce for the UK. So trying to get that global alignment with requirements is a high priority, obviously very challenging. But making rules just for the UK isn't going to go that well for organisations that operate globally. Overall, we wanted to reduce the burden, so that's reduce the burden on the sector. So that's things like administration burden, lots of different reporting mechanisms and tools, and ensuring that we're not being required to report on things without knowing what the reasoning is for it. So not reporting for reporting's sake. I also want to reduce the burden on the health system, so get things like the innovative technologies that are in our sector into the health system faster, so try and reduce that backlog especially. Patient safety and access to care, always a priority. I think sometimes I don't say it because I think it goes without saying, and it doesn't always. Obviously, patient safety is the utmost priority, and we would work every other way to make sure that that is still the priority. Reducing waste, and I mean that in all of the senses. So we want to reduce wasted time, again, things like reporting, we don't know what we're reporting for, but also reducing waste for manufacturers within their manufacturing sites, so increasing efficiencies, making sure that they're using all the materials, reducing waste at end of life, making sure that we're collecting materials at end of life, especially when we're talking about things like precious metals, keeping them in the system and circular economy. And also we want to make sure that there's consistency across the NHS in what's being asked. When there's differing requirements and goals, again, it's incredibly difficult for manufacturers to report for different jurisdictions. And the end goal would be consistency globally, whether it's obviously a much bigger ask. So these are some of the challenges. I'm not going to go into great detail on all of them, because obviously there's quite a few. But with the NHS, the lack of consistency in approach across the whole of the UK is a challenge. It's a huge challenge, especially when there's differing net zero goals. And again, I keep saying reporting mechanisms, but it is a huge burden on suppliers. And it doesn't necessarily mean that they're going to be reducing their impact anymore. I think a lot of time is spent in trying to reach these different requirements, which could be better used in actually reducing the impact within the manufacturing facilities. For social value questions, we know that there is a lot that's been going on over the last couple of years. They have been, again, quite challenging on suppliers due to some questions being asked that aren't quite appropriate or aren't quite relevant for the sector, and some of them not really answerable. We know that they have been getting better, but they are still very much a challenge that we're seeing for suppliers. Carbon reduction plans, everyone is on the journey to doing them, if not already done them. They were, again, challenging for suppliers to complete. However, we do know that they have raised the profile of sustainability within organisations to a much higher level, because you need that board level sign-off. Price, there's a lot of cost pressures at the moment on industry through things like Brexit and energy crises and the 0% inflation policy that the NHS has, which again makes it very difficult to fund all of these projects that they want to do to reduce their impact. I think the most consistently difficult one is the behaviour change. So it's trying to ensure that everyone within the health system and industry and academia and government is all on this journey together. But trying to change behaviours that have been in place for a long time is incredibly difficult, and that comes with things like when we're wanting to move to a circular economy, ensuring that we are using recycling bins and that we can put in these programs, and that we're not just doing the same thing that we always did by using single use every single time without questioning it. For government, it's ensuring departments understand the complexity of the sector. We're having ongoing conversations with DEFRA about how, because of where household waste goes, is not quite the same in the health system as it is across the board. So for things like extended producer responsibility, we are just a bit different, not trying to be the problem child, but we are just a bit different. And then moving on to regulation, it's things like allowing electronic instructions for use inside the regulation. We know that the impacts that these little paper packets have, but when they're in every single medical device, it adds up to a lot. It's the fuel that's used to transport them. It's the actual waste of the paper itself. And then there is the potential that there could be a higher quality of access if we are able to update the instructions for use regularly, including, as I mentioned before, moving to a circular economy, updating guidance around remanufacture and refurbishment. Because we know that there is some guidance, but we think the clarity around where liability falls for the OEMs and for the remanufacturers and refurbishers could be clearer. So that's a little bit of a taste of it. Again, there's quite a lot more in the paper. And these are recommendations that we made based on these roundtables and ongoing engagement with our membership. So with the NHS, as is not surprising, there's a lot of recommendations around consistency and an incredibly high level of engagement and ensuring that timelines are appropriate and achievable. The NHS England have been engaging with us, and it has increased over the last few years, which has been great to see. But we do want that to continue as we move forward through the roadmap and other requirements that may be the case. For the MHRA, as mentioned, it's approving the use of electronic instructions for use to reduce the excessive use of paper, potentially moving to a system of QR codes to improve information sharing, and providing clarification on the definitions of remanufacturing and refurbishment to increase certainty for suppliers, because it's these grey areas that organisations aren't wanting to invest a lot of money into work in, understandably so. And again, for recommendations for the government, we want to, we know that there's a number of funding opportunities and grants that are out there and available, but we think there could be a higher level of signposting from the government as to where these sit. We know it's quite a complicated landscape and it can be quite hard to find them, and certainly find ones that are appropriate for your organisation. We also want to establish a cross-government forum led by industry but supported with the Office of Life Sciences and Department of Health and Social Care, again to educate the other government departments on our sector and what is and isn't achievable, particularly when it comes to regulatory boundaries. So for things like with DEFRA, when they're wanting to, for extended producer responsibility, wanting to use more recycled content in your packaging, it's making sure that they understand that if it's primary packaging, then you need to know the origin of the plastic. So it's not, or that it's a regulated part of the product, sorry. So it's not as easy to change these things as it might seem from an outside point of view. So I wanted to talk about some of the ways that we're overcoming the challenges that I've outlined. It always seems a bit doom and gloom. Education. So the first step in all of this is for people to understand what it is that they're doing. So what is sustainability? What is circularity? What is scope 1, 2, 3 emissions? How can you write a sustainability policy? How can you write a carbon reduction plan? How can you actually then reduce your emissions? So within ABHI, we put on a number of webinars, and we have our sustainability conference every year, as well as our ABHI sustainability group, which has over 100 different companies in now, which I'm really pleased. It's the level of engagement is growing every week. It seems we're getting new members, which is great. But obviously that goes way beyond the work that we do as ABHI, and it's days like today and collaborating with Sustainable Healthcare Coalition and other organisations such as put at the bottom, but we're in a corporate partnership with IEMA, which is the Institute for Environmental Management and Assessment. And they're not health specific, but they're growing the health area, and they have a number of partnerships and members that are also within the health service as well. So it's trying to bring all of that together and increase that collaboration. Which moves on to the second point, which is collaboration across the ecosystem. I feel like I've already spoken to this, but it really does take a whole system change for us to move forward with this agenda. We can all do our piece, but it works so much better when we do it together. Engaging internationally, again, we speak to our equivalents globally, so the likes of AdvaMed and MedTech Europe and MTAA, our global counterparts, again, to make sure that there's that knowledge sharing to understand what's going on in each other's jurisdictions, because our companies are working on all of them, so it's best that we understand what's going on in all of them also. We also know that NHS England are doing a lot of global outreach as well, teaching about the net zero roadmap, and I know that a lot of other countries are looking to implement the system, which should hopefully reduce that administration burden and complexity of the landscape for suppliers. Learning from other sectors is a big one. So we know that we need to start looking towards, or already are looking towards, the likes of the food and drink sector, who are also quite heavily regulated. They are a bit different to us, but understanding how they've implemented systems that we could emulate in some way. Reconsidering product design is, again, a whole part of that education piece, but we know that members are looking at products they're designing now, although that's potentially quite long into the future. But we also understand that redesigning products once they're already in the system is incredibly difficult. We'd have to go back through that regulatory process and back through 100 different processes. So it's really important that we start reconsidering product design now as we move forward. Sharing best practice, again, it's through days like this and understanding what other companies are doing. And we try and ensure that there's that connection made within our membership and beyond that also. Conducting life cycle assessments, they are onerous and expensive, and we are by no means saying that you should do this across the whole of your portfolio in any way. But we do know that some members have done a life cycle assessment on certain products in their portfolio and then understood from that where the hotspots are, and then can look for those for other products. So they are useful, whether they are complex. Working alongside suppliers, so working down your supply chain, understanding where your suppliers get their products from and how they're transported, and whether they can move to shipping rather than flying in their materials or things like that. Investing in renewable energy, so whether that's with your energy supplier or getting things like solar panels, heat pumps. We also have our ABHI Sustainability Framework for Action, which is for our members, but it's a piece of work done with the consultancy a couple of years ago now. And again, it's a guidance document as to where to start with your sustainability policy, and starts explaining the kind of basic concepts, such as circularity and scope 1, 2, and 3. And then it gives you indications as to how to do things like materiality assessment and where to start thinking about it, and has certain considerations for SMEs as well. As I said, it's very representative of the industry that we have so many. So it was always important to ensure that that consideration was a part of that guidance document. So I wanted to talk about some of the industry-wide work that is going on at the moment. So Design for Life was launched back in March, I believe, of 2023. And this was a collaborative initiative started by the Department of Health and Social Care, and initially was looking at resource security and efficiency. But in turn, that is effectively circular economy for our sector. So it's ensuring that we think about our products at end of life and are not mining those materials all of the time, and relying on global supply chains as much to get them over here into the UK. So it's a huge initiative. There are, I think it's around 80 different companies and people represented. It's across academia, it's across industry, it's with government. We know that it's across the NHS within the UK as well, so it's not just based in England. And from that, there's been a series of workshops and launch events, and they came to these 6 problem areas on the right-hand side. So these are areas in which we need industry change and we need support in that in order to move to a circular economy. So separated into policy objectives, behaviour change, obviously this is a big one as I mentioned earlier, commercial incentivisation, so making sure we have those commercial levers and mechanisms for the health system to buy these products, so whether we're moving to servitisation or it's a different way of managing your contract, and we need to make sure that the health system can buy it rather than just the make buy model that is currently in place for a lot of things. The regulations and standards that will need to change, physical and digital infrastructure. And I found this part of the programme incredibly interesting because it was really focused around looking at what kind of decontamination and sterilisation facilities we have in the UK. And that is not fully mapped out at the moment as to what is both in the private sector and within the health system, what that capacity exactly is. And there was a huge amount of work done to try and find that out, but there's just not that written down anywhere in one place. So part of that work I'm very much hoping will include really mapping that out and seeing whether we do have the ability to move to a more reusable economy tomorrow. It seems unlikely, but then backing that up, it's the physical infrastructure and sterilisation and capabilities, but then also ensuring that we have the expertise and people that can actually run those facilities as well. So it's things like that that really are going to take the whole sector change to move forward. And then transformative innovation. So it's these innovations that will disrupt the care pathway, get people diagnosed sooner, treated sooner, and have an overall lower environmental impact on the care pathway. They also published their report recently from the first phase of this programme. So that's the MedTech Spotlight Report, Accelerating Circular Economy Adoption, which again is super interesting. I really recommend anyone take a read of it. So that is all from me. Thank you very much for having me. I'm happy to take any questions if there are any.
Thanks very much, Adi. That's brilliant. Alfie, as mentioned, you mentioned, but with respect to making, Alfie, why don't you ask your question?
Yeah, no, that's
that might
okay.
be the best thing.
I was trying to type and I'm walking and typing at the same time, which is always exciting. It just adds a flavour to the whole thing.
It does.
Sorry. So you were talking about it, but I'm also looking after a sick child, so apologies if you went into great depth. But with respect to the make to buy model, one of the things that I'm really, well, Wendy Rain is interested, and I'm sort of repping her at the minute, is I'm quite curious, are you discussing different service models? So service models that don't allow built-in obsolescence. So make to buy is, so you often have and so it's built to, you build things to break. I know it sounds awful, but that's the profit model that we have. So a model might be that I buy a device, a clean indoor solution device. I'm making something up because that's my area of interest. But actually it's a service model, so I buy into that product. So I might buy a 10-year service contract, and those devices come with it. Does that make sense? So, and the maintenance of, so is there any discussion? It may not be, but it's okay if you say the answer can be no, but I'm just, that might be an interesting thing, an economic thing. And Shaheen's nodding. If you have anything else to chuck in there, I'd be very interested to hear it, Shaheen.
Great.
So in terms, of, sorry, moving to those models, sorry, do you mean?
Yeah, so in terms of monetizing, so at the moment we make and we buy, and that's true within the Scottish NHS, right? We buy our devices, but actually we could move to a service model. So this built-in obsolescence could be deleted. So the stuff goes back to the man, it's a route. So the service arrangement could be that every year these things are taken in, rechecked, reserviced, and actually they stay in circulation much, much longer. Because you have a service model, you're almost renting the stuff rather than buying it. And that creates an obsolescence where we then are left with the stock, and then we pay for the disposal of it. And it just becomes this very linear rather than circular model.
Yeah, definitely. That's very much a part of the conversation for the Design for Life work. But we also have other members in our organisation that are already running programs very similar to that anyway, particularly for the bigger bits of kit. So things like the MRIs and the CT scanners, which I know are a bit of a different thing. But yeah, that's very much part of the conversation. I think it's ensuring that we have those mechanisms. But I think there's definitely interest from industry to do that as well.
Okay. I think one of the things we could maybe do is improve the contracting and procurement aspects of that, and to have some standard approaches. That might be quite interesting, don't you think, Addy?
Yeah, definitely. I believe that is a way that it's going to move forward with the Design for Life work. So I think it's ensuring that those are included within it.
That sounds good. And for some people, servitization as a concept might be new. Could you just tell us a little bit about that, Addy?
It's an ongoing contract with the health system to maintain products and keep them in the system, as opposed to just selling it to them and then you withhold any responsibility and it's just theirs now to look after. And it's working to keep sure that these products are working as well as they can for as long as they can, as opposed to just not maintaining them and letting them kind of go away.
Great, and Julie's given us a good example around peritoneal dialysis in the chat as well, so that's really helpful. Any other questions? And Julie's also saying it'd be good to understand the average life of reusable medical device as compared to others. Environmental issues. Do you have any thoughts on that? I mean, do we have any kind of data on that about how long, if you do have a servitization model, things last? Or
there is. It's just very case by case, as opposed to, I don't think we have an average as such anywhere that we can compare it to, but that would be incredibly useful to know.
But it's certainly something obviously we have to factor in. Shaheen's got a question as well.
It's not a question, it's just a comment that I'll be covering the servitization and average life of a product when you put them through different sterilization, decontamination. I'm just jumping in to say, leave something for me to present as well at the end.
We will, don't worry, there's going to be a lot to talk about. Very good. Well, thank you so much, Addy. Thank you also for all that hard work to pull together that report. I know you presented it in a few minutes, but I can only imagine all the hard work that went in to pull together all those conversations we've had over recent years into one place. And it's great to see that it also resonates with what's coming out of Design for Life as well. And it sounds like that recently published report's worth looking at. So thank you very much. And thanks to you and Luella for all your work with us as well. It's much appreciated. So I'm really delighted to welcome Mike Crooks, Professor Mike Crooks, who's Professor of Respiratory Medicine in Hull and York. And Mike's very kindly fitted us into a very busy day for him because he's actually in the Netherlands at another conference. So we really appreciate you joining us. And you're going to talk to us about some work that you've been doing on sustainable respiratory care and also overlaps with work that Rose Ingleton, our sustainability fellow, has been working with you on as well. So look forward to hearing your talk, Mike. Over to you.
Well, thank you very much. And yeah, thank you very much for having me. It's great to be able to join you. Let me just share my screen so that I can show you some slides. Hopefully, you can see them now. So the piece of work I'm going to be talking to you about is called the Sentinel Project, and it's about supporting high quality asthma care to drive improvements in clinical outcomes and reducing the environmental impact of asthma care. And I appreciate that I'm sure it's a diverse audience on this call. Not everybody will be an asthma specialist, so I'll set the scene a bit around asthma. But what I would suggest is that the vast majority of you will know somebody with asthma or have asthma yourself. There are very few people that don't know anybody with asthma, and we will have seen our friends, our colleagues, or family members often reaching for their inhalers and using them from time to time. And sometimes it's interesting to think about the context of your experience of that when listening to the evolution of asthma care and how we try and improve outcomes. So these are my disclosures. I work with across industry and healthcare, and I undertake research and quality improvement work. But I think that the most important disclosure relating to this presentation is that the piece of work that I'm going to be describing was a true collaboration. And this was a collaboration that was led by healthcare, so ourselves working in the asthma services within Hull in East Yorkshire, in collaboration with our primary care colleagues, in collaboration with our academic partners, and supported by industry. So with AstraZeneca providing really critical support to this program and then enabling its scaling. And I think that partnership working is really the way that we can achieve impact at scale to improve outcomes and decarbonize healthcare pathways. So just to set the scene about asthma then. So this is the definition of asthma. It's a heterogeneous disease, which means that it varies between individuals. So not everybody will have the same experience of asthma. But critically, it is characterized by airway inflammation. So asthma is an inflammatory condition. And that inflammation within the airways in the lungs is what causes the breathlessness, wheeze, chest tightness, and cough that those of you that suffer from asthma, I'm sure will have experience of, and those of us that know somebody with asthma may have witnessed. And that airway inflammation drives those symptoms through narrowing of the airways, and it's that narrowing of the airways which we like to identify when diagnosing asthma. So key to understanding asthma is understanding that it is driven by inflammation. And we often talk about wanting to achieve control of asthma, so asthma control, but I think we often lose sight of what asthma control actually means. And there's two elements to asthma control. There's the here and now, so how people are at this present moment, and we want people with asthma to be completely free of symptoms, both during the day and at night. We want them to be able to go about their daily lives without limitation. We want them to have normal and preserved lung function, and we don't want them to be relying on rescue medications, which are really there to do exactly as the name describes, which is rescue them from a dangerous situation, so an asthma attack. And of course, we also don't want adverse effects from treatment. So that's in the here and now. But what we also want to do is prevent future risk and reduce risk of future events, such as exacerbations, which is just a fancy name for asthma attacks. And we want to prevent those labile and variable symptoms. We want to prevent loss of lung function over time, and we want to prevent long-term adverse effects of treatment. And the treatment which is used to treat for asthma attacks, oral steroid tablets, have well documented long-term adverse effects. We want to prevent the need for those medicines. So when we think about asthma, and when you see pictures of people with asthma, what you'll often see is pictures of people using those blue inhalers, or people reaching for the blue reliever inhalers, which people use when they get symptoms. And those reliever inhalers provide very effective relief of symptoms, but that relief of symptoms is transient, because what those inhalers do is they relax the muscle around the airway, opening them up, but they don't treat airway inflammation. And therefore, when using those inhalers to relieve symptoms, they're treating, or essentially putting a sticking plaster on the problem, but not actually solving the underlying problem, which is that airway inflammation. And so there's now very well documented evidence showing that frequent use of those blue reliever inhalers, so that's 3 or more of those inhalers during a year, is associated with increased risk of exacerbation. So if we just think about that definition of asthma control, and risk being something that defines not having control, we know that frequent SABA use shows that people don't have asthma control because it puts them at higher risk. And that's irrespective of the severity of asthma. So BTS step 1 suggesting mild asthma, all the way up to BTS step 5 being severe asthma. Frequent SABA use, these blue reliever inhalers, is associated with risk of asthma attacks. And that's because when somebody with asthma is exposed to a trigger, the inflammation, that red line, starts to build. That drives the symptoms, and the symptoms means that somebody reaches for the reliever inhaler to try and relieve those symptoms. And they use that inhaler. It provides temporary relief, but ultimately that inflammation untreated reaches a crisis point when they end up getting those oral steroids. And the oral steroids then treat the inflammation, reducing the airways back to their normal state, and the symptoms are resolved. And that's really how an asthma attack looks in somebody who has a blue reliever inhaler, that SABA inhaler. So you can see how frequent SABA use is potentially harmful for patients in terms of reflecting risk of exacerbation, but it's also harmful for the environment. So there's been some fantastic research done characterizing SABA overuse in asthma, and this data is then carbon footprinting that same study. And uncontrolled asthma has 3 times the carbon footprint of controlled asthma, and that is largely driven by these short-acting beta-agonist inhalers, these SABA inhalers. And that's because the vast majority of these inhalers, over 90% of them, are pressurized meter dose inhalers. And those are the ones where you press the button on the top, the medicine squirts out the front, and it squirts out the front because there's a propellant gas carrying it, and that propellant gas has a high global warming potential, often over 1,000 times that of CO2. So SABA accounting for almost 2/3 of the carbon footprint of uncontrolled asthma. So if we can address SABA overuse in asthma, we can improve outcomes for patients, and we can reduce the environmental impact of its asthma and its treatment. And so how can we go about doing that? Well, there are other ways of managing asthma, and this is a way that's been around, and in fact guideline recommended for a long time now, but it's called maintenance and reliever therapy. And that's where we use a single combination inhaler that has both a steroid, which is anti-inflammatory, so it treats the inflammation in asthma, and a fast but long-acting beta agonist. So a medicine which will relax the muscle, open up the airways, just like the SABA does, but it lasts longer, and it's in a single device in combination with the steroid. So it's used as both the preventer in asthma as well as the reliever. So the blue inhaler taken out the equation. And the rationale for doing that is that, using this same illustration of an asthma attack I showed you earlier, as that inflammation rises and the symptoms start to rise, our person with asthma reaches for the combination inhaler as the reliever. They get that rapid relief of symptoms from the long-acting beta-agonist component, but they also get the extra dose of steroid treating the inflammation. So it prevents that exacerbation and maintains asthma control. And we know from numerous clinical trials over the years that that use of a single combination inhaler, both as the preventer and reliever, is associated with a dramatic reduction in the risk of asthma exacerbation. So this is a better way to manage asthma for the majority of patients. It's a safer way to manage asthma in terms of reducing exacerbations, and it takes the blue inhaler out of the equation. And as a consequence of that, this model data based on that same study, which I've shown you the data for earlier, shows that MART, as an approach to asthma management, that single combination as a preventer and reliever, has a significantly lower carbon footprint, even when used through pressurized metered dose inhalers, because fewer inhalers are used overall. So the top two on this graph being asthma treatment with a fixed inhaled steroid inhaler as the preventer, and then a SABA reliever, and the top being both as pressurized metered dose inhalers, the second being a dry powder inhaler as the preventer, but still with that SABA PMDI, which is the most common prescribed, and then the MART regimes as the bottom two, dry powder, of course, having the lowest carbon footprint. So we recognised within our region in Hull that that we needed to make a change and to, I suppose, look to identify and address SAB overuse. So just a little bit of context to Hull. It's a city in the east of England, and we've got a population of around about 300,000 registered patients across primary care, and somewhere between 18 and 20,000 asthma patients. And unfortunately, and despite having maintenance reliever therapy as our guideline recommended therapy for a number of years prior to this data, we had quite poor asthma outcomes. So we had the highest admission rate within our region. And when we looked at the prescribing data, this graph on the right-hand side of the screen, this is showing the proportion of inhalers that are prescribed that are short-acting beta agonists. So the higher you are on this graph, the more SABA inhalers that are being prescribed and the less inhaled steroid inhalers that are being prescribed. And that pink line right up at the top there is our local prescribing data in Hull. The dashed blue line in the middle is the national average, and then the dotted blue lines are the national deciles. So we were unfortunately in the top 1% in the country for SABA prescribing, which unsurprisingly translates then through to our poor asthma outcomes. So we identified that we needed to do something about that. And that's where the Sentinel programme came from, with our primary aim of improving outcomes for our adult asthma patients. And as a direct consequence of identifying and addressing that SABA overuse and improving asthma outcomes, we would reduce the environmental impact of asthma and its treatment. So if you look at the objectives as to how we achieve each of those aims, you'll see that they are almost the same. To improve outcomes, we want to reduce SABA overuse and increase appropriate use of inhaled steroids, and as a consequence of that, reduce the number of asthma attacks, both those in the community and those requiring hospitalisation. In terms of reducing the environmental impact, we do that by driving down SABA overuse, by reducing the resulting healthcare resource utilisation, which comes through asthma attacks, and where appropriate, increasing the use of dry powder inhalers over PMDIs, but recognising and always recognising that the right inhaler for the patient is the one that they can and will use. And if that is a PMDI that achieves asthma control, then that will also reduce the environmental impact, as we know that controlled asthma has a lower impact than uncontrolled. And we recognised that this was a complex issue. We recognised that SABA overuse is a very well ingrained behaviour, both for patients and clinicians. And to address that required collaborative working. So we undertook co-design, working with clinicians across primary and secondary care and asthma patients to identify the barriers to guideline recommended asthma care and what was driving SABA overuse. And we developed an intervention with these 5 components: healthcare professional education, specific prescribing gold standards to address our aims, targeting asthma reviews for those using SABA frequently, patient support and education materials, and also support for primary care colleagues to track their data in terms of prescribing so they could see the impact of any change that they were making. And we wanted to evaluate this robustly so that we could track changes in practice and be confident that it was as a result of the intervention that we were taking. So we rolled it out with a stepped wedge design, which really means that we rolled it out sequentially across the primary care organisations in our region, and we tracked the data during a baseline period before we started the project overall, but also continued to track that all the way through and to 12 months following completion of the programme in our final primary care network. And when we look at the overall change in practice that we saw, just looking at prescribing within the region as a whole, 12 months following completing the programme in our final primary care network, we'd seen a reduction of around 45,000 fewer SABA inhalers being prescribed following the intervention than if prescribing had remained unchanged compared to the year before we started the programme. And roughly estimating that on the basis of the majority of these blue inhalers being Ventolin, that equates to a carbon footprint equivalent to around 1,500 transatlantic flights. Oh, can we go on mute? Perfect, thank you. So just over the next 5 minutes, I'm just going to show you some slightly more detailed analysis from our pilot primary care network, where we've now got patient level data. So we've really been able to hone in on that asthma population and look at exactly what changes occurred during the programme. So this graph shows the proportion of inhalers that were short-acting beta agonists. So this was similar to that graph I showed you earlier with that pink line up at the top. But here the bars represent our pilot primary care network. Has about 2,500 asthma patients. And before the implementation period, we could see that short-acting beta agonist inhalers accounted for almost 60% of inhalers. The national median is the black line in the middle, and then we've got the 70th and 30th percentiles noted, just so you know where we sit in terms of national figures. During the implementation period, we saw a rapid reduction in the proportion of inhalers that were short-acting beta agonists. And most importantly for me is that change was then sustained for the months following. So we didn't see this as a short-term intervention where everybody then returned to previous behaviours, but actually we achieved a long-term and sustained change in prescribing practice, resulting in reduced SABA use. And in terms of what that meant for our patients, it meant taking patients from a high-risk group, so to begin with about 46% of patients using 3 or more SABA canisters per year, and therefore at increased risk of asthma attacks, and reducing that by almost 50% to just under 24% in the year after. Where 3 or more SABA canisters is associated with higher risk, 6 or more is even higher risk, and we reduced that population even further. And reassuringly, that theory and that association between SABA use and exacerbations bear true when we look at the exacerbation or asthma attack data. So within the population, we saw a reduction in the proportion of patients having asthma attacks, both in the overall population level, so in the 2,500 patients, about an 8% relative reduction. But in those patients that were high SABA users before the intervention, we saw about a 30% reduction in the proportion having asthma exacerbations. So really meaningful change in terms of risk and outcomes. And because of that positive data that we've seen within the pilot site and across our region, we've then developed Sentinel Plus, which takes this programme, packages it together very neatly and nicely and makes it available to other primary care organisations around the country. And it's now been taken up by over 350 primary care networks around the UK. And very reassuringly, when we've done analysis of the first 25 practices to take up the site, we've seen that same change in prescribing practice replicated that we've seen within our region. And across those 25 practices, with an average follow-up of about 11 months, we saw a reduction of about 10 to 11,000 SABA inhalers in the year following implementation compared to the year before, and an increase in inhaled steroid prescribing of around about an additional 5,000 ICS inhalers being prescribed. So very much that change in prescribing practice, which we know is associated with improved asthma outcomes, but also should lead to environmental gains also. So in summary, Sentinel project was co-designed, and I think that was really important in terms of addressing the barriers that were faced by clinicians and patients, but also in terms of creating that sense of ownership of the intervention and therefore driving implementation and uptake. Our preliminary data are very positive. Our full evaluation is ongoing, but I'm pleased to say is looking equally positive. And really, this program provides a scaled example of how improving healthcare and improving outcomes can then drive improvements in environmental outcomes. So thank you very much for listening. I shall stop sharing my screen and then happy to take any questions.
Thanks very much, Mike, and congratulations on all you've achieved. It's just great to see that. Kelly was wondering whether you'd also seen a reduction in oral steroid use, because you described how you've improved people's use of MART as an approach, but you mentioned oral steroids to begin with.
Yeah, absolutely. So that exacerbation data that I've shown you, that's on the basis of oral steroid prescriptions indicating an exacerbation. So we coded each oral steroid prescription as to whether it was consistent dose and duration to represent an asthma exacerbation, and that's where that data came from. So yes, a significant reduction in OCS courses.
Great, thank you. And you've obviously now got it around the country. Where next in terms of what you're hoping to achieve?
Yeah, very good question. So I think there's probably three streams to that. One is to continue to scale. We're in 350 primary care networks. Of course, there's over 1,000 primary care networks in the country, and we're keen to continue to roll out and support others to achieve the same thing. The second is that while we, with the intervention, have so far achieved significant improvements, there's always room to go further. So we want to consolidate those benefits within areas that have adopted. And whenever you scale a program, there's always variation in terms of success. So some will do very well, others will find it more difficult. And what we're really keen to do is to support those areas that are finding it more difficult, develop new resources and to help them to achieve those aims. And then the third stream is looking beyond our borders. So we've recently been working with Ireland to look at whether we can expand into their health system. And just last week, I was also across in Amsterdam presenting at a global respiratory leadership forum for primary care to look at how we could learn the lessons on a global scale.
Fantastic, really exciting. Alethea wanted to know, she said she might have missed it, but did admissions go down overall in your analysis and also in intensive care?
Yeah, very good question. So that is one area that we are still working on in terms of the data, because to get that, we need to link primary and secondary care data sets, which comes with many information governance challenges, and we are currently working our way through that. Of course, what we know is although asthma admissions are often preventable through optimal treatment, they are relatively rare events in comparison to other outcomes. So demonstrating significant changes in admissions with an intervention like this would be more difficult, and ICU admissions even harder to demonstrate because they are rare. But yes, we do intend to report that data when we can get it.
And then final question from Claire Taylor. Have you looked at whether the devices themselves that people can use can be made greener? Is that something you've been looking at?
So I suppose there's two sides to that. So one, in terms of the intervention, we support the use of dry powder inhalers where appropriate, and we have seen a significant increase in the use of dry powder inhalers over PMDIs. Just to give you an example, in that pilot primary care network, and this is data we hope to present later in the year, we saw about a 30 to 40% reduction in the carbon footprint of asthma care. 80 to 85% of that was driven by SABA reduction, but the remaining reduction was driven through increased use of DPI. Of course, there's a lot of work being done by industry to decarbonize inhalers with new propellants, which are all have their own challenges in terms of regulations and other things coming over years, but hopefully we shall see a significant change in that area.
Great. And I know they're also, from the plastic point of view, being reusable inhalers as well.
Yeah, absolutely.
Great. Well, thank you so much. And thank you so much for fitting us into your travels as well. We really appreciate that, Mike. And congratulations on all your work. And we hope that your message spreads far and wide, because you certainly deserve to fulfill that kind of impact that you were talking about just then. So thank you so much. We really appreciate you joining us.
Thanks very much. Great pleasure.
Thank you. So one area which a group that we often work with are health innovation networks. We hear a lot about them, and we thought it would be really interesting to learn a little bit more. And during the year, we've been working with Arup Nath and also his colleague John Craig. And Arup is the commercial director at UCL Partners in their enterprise division. And John, I think you're Chief Innovation Officer, as well as being deputy of the network itself. So we asked Arup and John to give some more insight into how do they work with companies, what do health innovation networks do. So over to you. Look forward to hearing more.
Thank you, Fiona. Let me just share my slides.
Yeah, thanks, Fiona. Hi, everyone. Great to be here. Thanks to Mike as well for a great presentation about the Sentinel Plus work. Let me say a bit about UCL Partners and what we do. Let me try and speak from the perspective of not just what we do, but why we do it, to try and get a bit, I guess, a bit behind the scenes of our thinking around the challenge of how can we help to make change at scale in health systems, which I guess is one of the questions that we all have in common in this session today. And just to say that something like Sentinel Plus is probably what great looks like, proven, ready-made intervention at scale for health systems to adopt. Next slide, please, Louis. So here's that sort of boilerplate slide about our organisation. We're a research, translation and innovation partner to 3 integrated care system from North London to the Essex coast. And the first thing that we have to remember is that we're trying to be a partner to people who barely have time to eat their lunch. I'm sure there's people on this call included in that. So I suppose the first thing to flag on this slide is this phrase that I've inserted into our strategy about life-changing innovation. It's not perfect, it's rhetorically slightly pompous. Life-changing isn't a wholly positive idea in healthcare, but I still like it because it's a benchmark for ambition. So we feel that we need to be working on things that we can talk to clinical leaders, hospital chief executives about, and that grab their attention. They speak to the 5 biggest things they're worried about, the 3 biggest things they're excited about, because that's the level of ambition it takes to get engagement from a system this busy. Otherwise, why don't they just go eat their lunch? So pompous but necessary, just a level of ambition. Thanks, Ruth. Here's our geography. Obviously, our geography is the best geography, etc., etc. I suppose the thing to say about it is it genuinely is that mix of some of the richest and some of the poorest parts of not just England, but Europe. And so these are systems that think a great deal about health inequality and are certainly challenged by it. It doesn't matter how kind of rarefied and brilliant the tertiary centre you're sitting in is. It's only ever a couple of stone throws from spirit-crushing poverty. And so that theme of tackling health inequality runs through everything we do. And if it's not there, our partners will challenge us and disengage, very understandably, given where we work. And the other thing about our partners is they're fairly brilliant. People like Moorfields, one of the leading eye hospitals in the world. So we have to be really clear and think really critically about the value that we're adding. I've been at UCL Partners just over 18 months. My first week, a kind of very clever cardiologist challenged me to say what UCL Partners is and what it did. And I said something stupid like, we connect you to the knowledge base. And he kind of like looked down his half glasses at me and said, I am the knowledge base, Sonny. Like, where do you think you come in? And it is quite easy to drift into that kind of vague thinking about the value proposition. So we try to focus on priorities and problems where some of the knowledge that you need to solve those challenges is not in even the smartest clinical centres. And of course, that's why climate is actually a really positive area of work for us, because so much of the knowledge, healthcare engineering, detailed around estates management, logistics, whatever it is, around a net zero NHS just isn't in even our best hospitals. So that makes it a really kind of fertile place for our work. Thanks, Ruth. As I said, Sentinel Plus is a lovely example that Mike spoke about. Where we're trying to get to is impact at scale, not just across our 5 million person geography, but if we're doing it right, these things should scale nationally. Our proactive care work in cardiovascular disease now in 600 primary care networks. Frankly, we just want more of those kinds of examples, proven interventions having an impact at real scale. Thanks, Ruth. So a couple of things about how we do this. The first is that we've restructured our company really around a single notion of a pipeline of innovation. So reading from insights on the left-hand side all the way through to implementation and evaluation on the right-hand side, starting with ideas and ending with proven impact at scale. And we are 90 or so staff at UCL Partners. We're all now collaborating around supporting a single pipeline where we include all our projects mapped by their level of maturity. And that's a process by which we integrate the work that we do with academics and researchers, with innovators and companies in the private sector, and with NHS colleagues, so that we're all working towards developing and testing ideas and then prototypical solutions to develop models, Sentinel Plus being a good example of impact at scale, which have become super easy for NHS systems to pick up. We know that the NHS is hard pressed in terms of resources and workforce overall. Some of the particular pressures are actually in leadership capacity and management capacity to engage with and implement innovations, and certainly capital is hard to come by. So being really, really targeted about the few implementation projects we want to bring to scale in our geography is vitally important. And our job is that by the time that they get to a proposition for our system, they're really, really ready to go. And our experience is they're likely to include not just one innovation, but just as in Mike's example, many innovations knitted together to work seamlessly to reliably get to the better outcomes and savings that we're promising. Next slide, please. And we have a set of priorities. I think crucially for us, we really stick to them. We are working on a set of priorities that we think that we know are of central importance to our NHS partners, but also resonate equally with academics and researchers and innovators across healthcare nationally and internationally. Sometimes my colleagues say, please give me a better reason why we're not doing this project, other than it's not one of our priorities. And of course, I don't have an answer to that other than sorry. We maybe a couple of years ago were a company that talked about changing the world and had 100 projects, and that each of those problems was brilliant, but that adds up to an organizational problem. So we now have fewer projects, and we try to be as decisive as we can, which is about, I guess, facing up to the scale of the challenge of achieving change within any one of these priorities. Within each priority, we're a problem-first organization. A risk for health innovation networks is that you come across like an organization pushing gadgets. We're an organization seeking to solve problems. And when we've defined a problem with a key partner that makes sense in terms of the evidence base, is a genuine problem and for which there might be solutions. So it's really an innovation problem, not a money or a management problem. Then and only then do we go at it and use those resources across our innovation pipeline to try and solve it. So that's just a little bit of, if you like, the kind of core story of UCL Partners, but just trying to unearth a bit of why do we work like this, given the scale of the challenge of kind of making change in the NHS. Maybe just say a little bit about what we're doing in climate. We are doing a piece of work with NHS England around nitrous oxide. Some hospitals have done some great work reducing the use of nitrous oxide, which, as you know, is about clinical change, but also engineering, preventing leaks. We're working to really define that work in the very best toolkit that we can build and scale the impact of those changes nationally. We've been doing a piece of work called Connecting for Change, As I said, a lot of the knowledge needed to get to net zero is not inside healthcare institutions. That's about connecting researchers with clinicians and healthcare leaders to do collaborative research together. One of the projects, for example, is around turning operating theatres off at night. Big gains, very scary, but it can be done with the right safeguards. And lastly, we've for quite a long time now been exploring power purchase agreements, looking at how to leverage the huge amounts of money that hospitals spend on energy to generate new investment in renewable capacity, currently made fairly impossible by Treasury rules, but we think they could change and they ought to change, and we'd love to be some of the innovators that make that happen. So that's just a bit about how we work and what we're up to. I'm going to pass over to Arup, as long as we've got time, Fiona, to say a bit about our work in the commercial space specifically.
Great.
Thanks, John. This can be a tough act to follow. So I'm going to talk to you a little bit about our specific offer to innovators. When we say innovators, we mean the folks on this call, basically. So people from large organizations such as pharma companies, all the way to clinicians with an idea, or a PhD student with an idea, and everybody in between. So I'm just going to talk to you a little bit about our offer to innovators and end with a couple of examples of how we're working with some of those innovators, and finally end by an invitation to folks on this call to reach out to us if you would like to collaborate on projects. So in terms of our offer to innovators, I'll start off by talking about the impact that we have by giving support to some of those innovators. So as a network, 15 health innovation networks, we engaged with around 5,400 companies last year. So we had 5,400 interactions with 2,800 companies last year, which resulted in additional investment of £428 million into the English economy. And that resulted in more than 1,300 jobs either created or safeguarded as a result of our engagements with them and the support that we provide these companies. So what sort of support do we provide to create this impact? This slide is a vast simplification of what we do, but it provides a good framework for how we deliver some of that support. The key thing to say is that our offer framework is designed to drive the spread and innovation of proven technologies into the health and care system to create long-lasting impact at national scale. And it's that national scale and long-lasting impact that's really important to UCL partners, but also to the network itself as a whole. So we basically tried to think about our offer to innovators in three ways. So the first is a universal offer. We give this to all innovators, as I said, that run the gamut of size and complexity. And we do that at no cost, and we provide that to UK and international companies. As Fiona will know, we provided some of that support to Japanese companies as well recently. And then beyond that, we provide enhanced support where we think solutions meet local priorities or unmet needs. And here we would invest time as a company to provide that bespoke support. And finally, beyond that, we provide very distinctive, long-lasting support to do certain projects. And this is what we're really interested in terms of potential collaboration. So working with, say, pharma companies and collaborative working agreements, or smaller SMEs to do real long-lasting projects, such as the Sentinel project that was just talked about. The kind of things that we provide to innovators are mainly in the sort of blue boxes that I've outlined there. As a health innovation networks, while we can provide some high-level support on clinical development and clinical validation, what we're really designed to do is to provide that path to adoption and scale for proven innovations, so innovations that have already been clinically validated. So the things that we're able to sort of help with are things like market research, real-world validation, and scaling up. So this is around pilot sites, reference sites, et cetera. And again, for our conversation today and for the folks on this call, that's probably what's really interesting. So I'll give you a couple of examples of how we've been engaging with some of the companies. So in terms of pharma companies, there are I know there's folks on the call from Bayer, Novo Nordisk, AstraZeneca. So we've already been engaging with these sorts of companies to look at projects within some of our priority areas, including climate in certain instances. And I would also invite folks from this call to reach out to us if you have other ideas for projects, including in the climate space. In terms of SMEs, some of the example projects and innovators that we've helped are a company such as Zedible. So they help to quantify the impact of ingredient substitutions in menus, and that can lead to massive gains, financial gains, as well as net zero gains for hospitals. Another example is a company called Revolution Zero that we're helping out, and they do reusable PPE, and we're helping them to basically scale up their offer from Cornwall, from Guy's and St. Thomas's, and start to think about how they can bring it in to North London and Mid and South Essex. So that's just a really quick whistle-stop tour of our offering. As I say, if you are interested in engaging with us on any project in the climate space or in any of our other priority areas, please do reach out to myself or John. We'd be very keen to have a conversation with you. And yeah, now very happy to take any questions or discussion points. Thank you.
Thanks to you both. And not only have you described the what you do, but the why and also the how. So thank you so much. And that point about focus, I think, is incredibly important if you're going to have impact. Michelle, you've got a question, please.
Yes. Hello, Michelle Sullivan, Boston Scientific. I really liked your phrase, pompous but necessary. I might steal that, actually. I thought it was a genius phrase. I wanted to know, how much do you get involved in scaling up proven technologies and procedures for patients? Because there seems to be a real lack of focus on this just generally. And so we end up with all this inequity all over the place. And every time we look, there's places that can't get access to things that really would make a difference for patients. And obviously, as we know, the most efficient pathway is the most sustainable pathway. So I wondered how much you got involved in that rather than these brand new innovations that are coming through. Is there any of that going on?
Thanks, Michelle. Yeah, I'd rather you steal that phrase than quote me. So that,
I won't quote you. I'll just steal it.
So where our big focus is getting to major implementation projects that implement proven interventions at some scale. And in order to get the level of engagement we need from our partners, we need to relentlessly focus on research, translation, and innovation. And so, in a sense, partly I think your question boils down to like what scale is big enough and what level of penetration is enough. And so somewhere between 20 and 50% is where I think an innovation organization needs to stop, because either someone's determined not to do it or it needs to become business as usual. So that doesn't mean starting with the best of in any sense. Sometimes it's about innovating to solve challenges that are most significant and most important for our poorest patients. But we health innovation networks need to avoid trying to be a kind of rival source of system coordination or performance management. So that handoff is tricky, and I appreciate your if you like, your frustration that the best you see isn't everywhere. And if you like, the kind of inequalities that we see in our system. I think our best approach to that is to pick the right problems and build the kinds of solutions that can help to make a more equal healthcare system over time, and still be quite measured about choosing when to stop our role and hand things over to the system.
Yeah, it's often the most deprived areas and patients who just don't have the resource wherewithal, whatever it is, to fight for the things that they could get. And I'm just wondering if that's something where that your networks could step in from that perspective, if you see what I mean.
Yeah, I think that it's easy to operate with the stereotype of an innovation as if it's some form of new technology that a patient needs to work hard to adopt. And if that is the default, inequality is going to stick with us. But there are forms of innovation that just mean the patients who most need help get it proactively offered to them face to face in a way by people they already trust in a way that works for them. So I think there is that thing about just having integrity in your innovation strategy and going to the right problems for the right people.
Yes, thanks very much. Very interesting.
Great. Any other questions? Maybe, Arup, if I could ask you one. You kind of put out what you do to support and work with commercial partners. What's the best starting point for anybody listening on the call now? Where would they begin in terms of contacting the Health Innovation Network and you and John?
Yeah, so we can share this slide out, Fiona, and at the very end we have an email address there. We can also put it into the chat. But I think the best way is to think about areas of unmet need, and then to bring that to us. And then, as John says, we're a problem-first organization. So for us, having that unmet need, understanding specifically which problem we're going to address is really, really important for us. So as John says, so that we're not doing 100 projects, but we're doing very few, very high impact projects. So I would invite anybody to sort of contact us, and we can sort of have a conversation about what those projects might look like.
Alethea was mentioning that she's partnering with you at the moment to review a tool that UCL teams developed, and she wondered, could you talk a little bit more about the other work you're doing on nitrous oxide?
Yeah, well, thanks, Alethea. I'm going to thank you in advance for your insightful review of that tool. I think what we've been doing is trying to get alongside, thank you for your work on it, get alongside some of the hospitals in our geography that have been leading the way, understand in detail what they've been doing, and then build that into the tool that we're designing. But to be honest, that task is at the heart of that work. And if you respond and make sure that you speak to Claudia Rees, REES, she would be the best person to pick up with. It could be a really productive conversation. If you don't have any joy, please feel free to contact me directly. We're going to share these contacts in a sec.
Great. Well, thank you both very much. That was a fascinating talk. Great to hear about all the impact you're already having and the opportunities to collaborate with you further to make even more happen. Thanks again to Arup and John for a really fascinating talk. You managed to pack so much into a short period of time. Thank you. It was brilliant.